quantum of improvement in healthcare. We talk of quality of life based on the investment made. With point of care testing, this has enabled us to have a minimum investment in healthcare infrastructure. And one key development which has happened in the past decade is telehealth platforms. So I don't see any way we can have telehealth platforms operating effectively without point of care testing modalities. So just to streamline and to make a quick comparison of the workflow of a point of care testing platform versus the mainstream laboratories. So you order your test, you prepare your test materials in both cases, you collect a sample, and with point of care testing, you move straight to your point of care device and boom, you have your results. Usually most of them are within a minute to about at most 20 minutes, but most and averaging about 10 minutes for you to get results especially in biomarkers. But if you look at the workflow of a laboratory testing, you look at the package sample, you sample it, you transport it from one place to another. Sometimes it can go across borders, sometimes within cities of the same country, sometimes within suburbs of the same country. Then it goes into the lab, it's logged in, and then eventually the scientist performs the test and the laboratory communicates the results, sometimes after days or sometimes via emails to the patient. So then you eventually obtain your results. So depending, you see the advantage of point of care testing in terms of timeframes and also in terms of convenience. Along the whole channel of mainstream laboratory, there are additional costs associated with the actual test, which build up to give us the value or the price that we eventually pay to obtain the results. Going back to diabetes, as I said, I'll focus on diabetes, but I'll also go into other metabolic conditions and present on the point of care testing that are there. One of the key fundamentals of diabetic management is the reduction in the glycated hemoglobin, HbA1c. So we see that any decrease of the HbA1c above normal to normal of 40%, you reduce myocardial infarction. By 14%, you reduce microvascular complications. If you reduce by 1%, you reduce microvascular complication by 37%. And the risk of death or major limb loss goes down by 43% for each reduction in HbA1c. So but HbA1c results come after a while. And what do we do to lead towards the reduction in HbA1c? We need good monitoring systems for the patients, either for your fasting plasma glucose or your postprandial glucose. So hence point of care testing devices in diabetes developed much faster and are more robustly acceptable by either our population or the healthcare providers because of the investment that has been done to make it very normal and very regular and standard for a patient who is diabetic to be monitored through point of care testing. In fact, another step going to self-monitored testing. So just to further put that, we can see the importance of monitoring and point of care testing. As you see on that graph, the light blue representing the fasting plasma glucose and the dark blue representing the postprandial glucose. In the initial stage, is when you are well controlled, you see that there is a bigger contribution of postprandial glucose to your HbA1c control than the fasting. Then as you go towards poor control, fasting plasma glucose becomes important. So this has got a bearing on monitoring. But in all, we encourage target both fasting plasma glucose and 2-hour postprandial glucose. Both self-monitored blood glucose and monitoring devices by healthcare practitioners are used to do point of care testing in diabetes. We have the usual on-demand meters, e.g. your standard glucometer, which we are all familiar with. But I want to speak about continuous glucose monitoring meters. And I'll also speak on point-of-care testing using the HbA1c devices, as this is very, very key. There are various brands and types available. As I said, we on top of our standard pricking systems, where patient pricks themselves and then they manually put the blood onto the testing strip, and the client, then the patient then reads the results from the metering device. The disadvantage of this is that it's cheap to buy, but you then, if you look at it, you need your lancet, you need your swab, you need your strips, which on average, most strips here for 25 to 50, they cost about $8. And then, of course, the money that you buy the device on is also included on that. But for continuous glucose monitoring, which in most jurisdiction for now, some of them need a prescription. But these non-prick systems, there are various types. There are those that you don't pay with your phones or you don't pay with your watches, e.g. the Libre 2. But what you do is I'll show you the image. This is the one on the right is the Libre 2, and then the one on the left is the monitored mobile device monitored meter. So they also have an advantage of you getting real-time results without pricking yourself, but at the same time you get a trend which is visually displayed on your meter, which shows where the glucose is going. So and even before the glucose is high, you have an indication that you have got a reading of 8 millimoles per liter, but you expect your sugar to go up. So that meter, it shows you, like on this, it shows you this arrow, it will be showing that you're above 112, but it's going to be up in the next couple of minutes or hours. So then there is another device that is connected to your smartwatch. And the importance of this one is that you can set up your app such that the healthcare providers will be able to also have access to those readings, either real time, if there is a connectivity between the two, or in a shared format, if there's a network connectivity via either any other social platforms that we use in the medical industry or via Wi-Fi. The important thing about continuous glucose monitoring is that you prevent the big elephant in the room for diabetic management, especially for those on insulin, which is hypoglycemia, because you can actually see where the trend is going. You can have access to current sugars and whether it's going up or down. Then there are other benefits of continuous glucose monitoring, where you can connect, because this is connected wirelessly to your machine. You can put a trigger region range for your alarm for the device, so that if your sugar is going down, then you get a trigger. If your sugar is going above the range, you can put a trigger. Then the patient can be able to see and print out the results and show the doctor, who will then be able to, or healthcare provider, who will then be able to adjust the treatment accordingly. And you can also link these devices with your insulin pump, such that if you've got an automatic insulin pump, it can adjust the rate at which it's infusing the insulin, either up or down in accordance with the readings that are being churned out. We also have practitioner inserted sensor devices, where you insert a sensor in the subdermal, and these are longer term systems which last about 90 days, 180 days, and then the patient scans or connects their sensor onto that inserted sensor to get a result onto their device or onto their phones. One important thing about continuous glucose monitoring is that we are able to match your habits with the glucose profile. and being able, like the Guardian Connect, you are able to do a predictive alerts, which will show us that the sugar will go up even before the sugar goes up. So you are not waiting for the sugar to go up and cause problems, but you can get an alert, a predictive warning that the sugar, because you've done A, B, C, D, or you've eaten this, the sugar will go up by this range, then you control. And some of them are coming with the sugar IQ feature, which helps to determine which diet, which exercise, or which insulin is best suited for you. So that's on glucose monitoring using the self-monitoring, which are linked to the healthcare practitioner. But for long-term monitoring, we have got devices. The point of care, there's the standard HbA1c meter, which are on big immunoassay machines found in the mainstream laboratories. But we also have point of care testing, glycated hemoglobin machines, which are, as you know, HbA1c is important for both diagnostic and monitoring. But however, literature shows that it's more suitable and for prediction of complication, that is for monitoring, than for diagnostic purposes. Our range is being under the American Diabetic Association. There is a range of 7%, but mostly here in Africa, we use the International Diabetic Federation range, a cutoff of 6.5% for good control. But for diagnostic purposes, if somebody presents with a range between 6 and 6.5, we normally classify them as pre-diabetic. But I'll give a warning that we will need then to use fasting plasma glucose as in association with that pre-diabetic mark to come up with a proper position on the status of the patient. One of the instruments that we have used is this rapid fluorescence immunoassay, the RAFA machine, which uses immunofluorescence to measure levels for other metabolic diseases. As I said at the beginning, that we are looking at a wide range of metabolic diseases, which are not just hormonal. We are also looking at cardiometabolic. We are looking at renal. We are looking at other non-communicable diseases like cancers. So the RAFA machine, which is the rapid fluorescent immunoassay machine, has got cassettes that are quantitative, not qualitative. These are quantitative. They can give us a range, which then looks at hormone levels, and they marry what we have using the bigger lab offered machines, and the results come out in about between 3 and 10 to at most 20 minutes, depending on the test. So I look at hormonal tests, we look at your cardiac biomarkers, we look at infection biomarkers or inflammatory biomarkers like your CRPs. Then you've got your diabetic, which is the HbA1c, and you look at markers for renal injury and cancer markers such as your prostate-specific antigen, CEA, CA125, and the like. What is your choice when you're looking at the choice of the point of care testing in metabolic disease, or in general? You want one that is suited for a wide variety of healthcare facilities that can produce fast results. That's one of the key criteria that you look at when you're choosing a point of care testing. Then one that can be used in the outpatient centers. You can use them in laboratories or in small clinics in the rural setup or in remote areas. And you can also use this in other level of health centers. And then you also look at specialties which you'll be in or which you are most likely going to deal with. Cardiology, as I said, your respiratory, your pediatrics, and the like. And you want also one that is able to offer quantitative testing at the point of care, because it's good to have, let's say, a PSA rapid, which just shows you that it's negative, meaning that it's less than 4 nanograms per mil, or it's above 4. But you also want, for continuous monitoring, to be able to pick the quantity. If you have a baseline PSA as an example, or 5, and then it comes out 6 after 3 months or less than 6 weeks, then you know something progressive is happening. You also want a pure CT that is consistent and accurate, which gives accurate results through data variation that is less than 20%. You want one that is also need to remove the need for visual and subjective interpretation of results. You want something that is that is in black and white. If it's positive, if it's high, it's high. If it's abnormal, it's abnormal. You want one that is also compatible with any type of laboratory information systems. Why is this important? Because imagine you are dealing with a point of care testing device for metabolic disease, and you're in another area, and you need specialist help or to transmit information for further care. If you have a machine that is compatible with the laboratory information system, then you are able to share that information real time and be able to improve the patient outcomes. So, as I said, which panels are available for our metabolic diseases? There are quite many, as I said, classified in various ways. For your cardiac, I would like to emphasize the common ones. You've got your CKMBA, which comes as a quantitative, and you've got your natriuretic brain hormone, which is the pro-BNP. This we use in cardiac failure, not to diagnose cardiac failure in isolation, but you monitor the extent of cardiac failure in a patient. We have your myoglobin, you have got your D-dimers, which are very, very useful. I think it's one of the commonest requested cardiac biomarkers, more so post-COVID, where we are witnessing a lot of vasculitis, or post-COVID injury, or post-vaccine injury, or prolonged long COVID, where this becomes a very useful test. And what more if you have it as a point of care testing device. Then in renal injury, you have got your microalbumin urine, and of course the HbA1c that was just spoken about, and cystatin, which is also a marker of kidney injuries. Then you have your hormonal tests. You've got your beta ICGs, which is multiple use outside of pregnancy. You've got your thyroid stimulating hormone, your prolactin, luteinizing FSH, and the like. You also have your total testosterone in either total testosterone or free testosterone, your progesterone, and indeed in fertility clinics where they might need to have a one-stop center for fertility. You have got your anti-Mullerian hormone test. It's usually a very expensive test, but if you're running it as a point of care testing, I think the cost is less than $10 per person per test. Then you've got other cancer markers, as I said, your CEA, coronary embryonic antigen, your alpha fetoprotein, and your vitamin D. It's becoming a very important test, especially in metabolic diseases, not just in hypovitaminous D, but linked to, because of it's a very important marker. If you've got low vitamin D, it usually indicates a high inflammatory state. So in diseases which are inflammatory diseases like diabetes and many others, then vitamin D levels become very key in that. You can have your CRP, which is important in both cardiac and infectious diseases. Calcitonin there, which is also good for infectious diseases. Looking at, I'll just focus on the test that I would say highlight as important ones to consider in metabolic diseases, especially if we can categorize them by disease system, like in the renal, acute renal injury or chronic renal injury, but usually in acute renal injury, you have your microalbumin. Not as, you can use a rapid test strip for urine, which is qualitative, but as I said in the preamble on metabolic, that you don't want something that is ambiguous. You want something that will tell you that your microalbumin urine is at this level with a working range between 2 and 300. Your normal, it has to be less than 20, but you want it even lower than that. Usually we use, if you combine with urine albumin creatinine ratio, you put it less than 3.4. So you can use this as a marker for kidney injury. Usually in conditions like diabetes mellitus, where there is really that's micro albuminuria is one of the key markers for complications of diabetes. So it's quite a very useful test, more so even in terms of cost and in terms of accuracy. Then you also have a very specific, the cystatin C protein, which is specific for diabetic kidney injury. So it becomes a very valuable tool. Sometimes you can use the two in combination. Of course, I've spoken about your HbA1c. Before I come to cancers, I want to go to one test that is becoming commonly requested, your ferritin test. Obviously, we would ordinarily use it for our anemias, iron deficient anemias, but or in people with iron overload, to those who go through treatment or through bleeding. But ferritin, as you know, it becomes very important in dealing with other inflammatory diseases such as liver diseases, rheumatoid, and in hyperthyroidism as a marker of somebody who is going into acute thyrotoxics or thyroid storm. So together with clinical markers in thyroid storm, you find that a very raised ferritin level is a predictor, besides your clinical scoring system, which we use to detect or predict thyroid storm. Ferritin becomes a very key test in that. But in liver diseases and arthropathies, you find that this will be very key. As also as a cancer marker, blood ferritin is usually an important test, which is becoming increasingly requested and important. I spoke about vitamin D as it's becoming very important obviously in diagnosis of your diseases, your calcium diseases, but also in monitoring of patients who have got severe inflammatory conditions in malignancies, in other metabolic diseases. In other cancer markers, the very common cancer we have in our setting, especially in the Black population, we have your prostate cancer. And as I said, this is a quantitative test, so it helps both in diagnosis together with clinical examination or digital rectal examination and your imaging, which Jackie was showing in the mobile. Imagine if you have your PSA, total PSA quantitative, and you have your ultrasound scan mobile device, then you have a winner there, because you'll be able to do a clinical examination in one visit. You take your history, you do your clinical examination. From your history, you've picked up this person has a sign of enlarged prostate or hematuria, or they have agency, or they're having severe back pain, they're losing weight, they're pale. Then you do your PSA. You realize that the PSA is high, and you do a Doppler ultrasound scan, with using a point-of-care testing device. And it means in one setting, this patient has received a comprehensive assessment. And in some cases, if you're a surgeon or you're experiencing that, you're a urologist, you can do ultrasound scan guided biopsy of the nodule that you would have picked up, because of, the patient can literally move from one room to another and get everything done under one roof because of point-of-care testing. Then you have our carrion embryonic antigen, which is important for rectal cancers, your ovarian or lung. I mean, we use this as a screening tool. It's as you can see, it's a very wide approach. Then you have got your alpha fetoprotein, which is important for your testicular cancers, your brain cancers, and then your liver CAs as well. As you know, testicular cancer has got a very high metastatic rate, where it can just move local disease in the testicles, metastasizes to the brain. So alpha fetoprotein as a biomarker becomes very, very important, especially if it's readily available at a very good cost for people to get it. I'll also talk about on the test menus that we have. I can talk about if you look at the test menus, we have got your prolactin. Prolactin, I was working at PARI, and one of the key issues was that we had people presenting with blindness or visual tract defects because of prolactinomas, which would be compressing the optic chiasma, resulting in damage of the optic nerve, especially the optic chiasma, and obviously vision loss or vision impairment. And the average prolactin test, if you are not doing it to dilution, your standard test would be above $35 per test. And a lot of people in the public sector or in remote areas might not afford that, to the extent that if we have a point of care panel like this, where you do your clinical examination again, you pick up somebody with headaches, visual disturbance, loss of visual fields, and with if it's a female, maybe with the deranged menstruation, or they've got a galactorrhea. And imagine in a specialized endocrine clinic, you are able to do your point of care testing. You run your, amongst other hormones, but you run a panel of your prolactin, and you do your other anterior pituitary hormonal assays like your TSH, your luteinizing hormones, and all those things, and you are able to pick it up. It means the time frame of a patient coming to get the history, awaiting to get results, come back for confirmation, going to get imaging, and then coming back again will be reduced. Meanwhile, the tumor is growing, or the clinical consequences of raised hormones keep on causing havoc to the patient. But you have a pure CT, you are able then to get those outcomes quickly. I mentioned one-stop fertility tests. You have all those other hormones. Or if you do a clinical examination, you find the patient has got signs of hypothyroidism or thyrotoxis, or signs of hypothyroidism with a nodule or a multinodular goiter. If you have an ultrasound scan, point of care ultrasound scan, together with confirmed hormonal assay on point of care testing, what it means is you are able to evaluate the nodule or the nodularity, come up with your thyroid score, which will indicate whether it's cancer, pro-cancerous, or it's an innocent looking one, or the person has got your overt thyrotoxicosis or Graves' disease, where if you just run your thyroid hormones, T4, TSH, and you do an ultrasound scan, you're able to institute management without that doubt. So this is the kind of level we are looking at. But there's also the level where we are looking at telemedicine, where we can set up localized virtual centers in certain areas, where people or communities can access this at these reduced costs and quick turnaround time. And they can have a doctor or a specialist or a healthcare practitioner somewhere online. And let's say a trained healthcare practitioner who might not be a specialist sitting with the patient, they do the test after training, and they're able to produce these results. And then the results are shared through the information management system, or that's just through your normal telecommunication devices, even via secure WhatsApp. And then the specialist can give a management protocol, or a patient can be moved from one area to receive surgery, urgent surgery, because of that. I mean, we cannot talk of the value of point of care testing in emergency rooms. Right now, if you have a patient you are suspecting to have myocardial infarction, you might wait. Of course, you might start treatment on clinical basis, but you have to wait for a couple of hours, or in some care centers, at least 2 hours for you to get results. But you know your troponins and your D-dimers and your CKMBs are time dependent. And by the time you get the results, you have lost a window of period to manage the patient. So that's the value of this point of care testing in metabolic diseases. I think I could say a lot, but I would allow this time for us to have some questions, and maybe my team there can help in looking at if there are any questions that are in our chats. Maybe we can take some questions at this moment, those that have been written down prior, or if there's anyone with a question, we can do that.
Dr. Masiya, thank you for that presentation. I just want to give an opportunity to Dr. Stone so I see that she's written a couple of statements in the chat. There are no questions currently, but Dr. Stone, would you like to make some comments or questions? And we'll wait for everybody else to write their questions in the chat.
Thanks, Dr. Masiya. That was a brilliant presentation. I think that one of the people, or one of the groups that have set the standard have been the aviation industry, because for the last 15 years, they've been managing patients who are over the middle of the Atlantic while they are on the ground somewhere else in the world. And I think that we are only just beginning to embrace some of the technology, particularly the technology that links to an electronic medical record. And there are a lot of systems at the moment where you can be giving a patient a device that they can have at home, and they can monitor their blood pressure daily, and you will only be alerted if the blood pressure is out of range. So I think this, in a Southern African context with a lot of rural and remote patients, could be a game changer. And if we can basically image the lung, image the abdomen, and be able to do some of these blood tests, we bring the laboratory and the imaging centers into one place. And as GPs, we can actually take back control. And I'd just like to hear your comments on that. When I trained, it was hammered into me, the golden hour. If you can institute definitive management based on a correct diagnosis within the first hour, the outcomes are so much better for the patient, and they are so much cheaper for the healthcare system because the patient doesn't progress to ICU. So I'd just like to hear your comments on that, really.
Yeah, that's a very, very valid commentary, where the quicker, I mean, you're looking at various segments of patient care. You're looking at the patient themselves. Obviously, the most important outcome is the outcome of the patient. But you're looking at the journey that the patient will walk through from presenting at a healthcare center to them either being admitted, which is what we don't want, or to them getting sorted and going home. So if you have good diagnostics which are on site and giving real-time results which are reproducible and of quality, which are quality, we are able to then make critical decisions definitively, and with products being available, we're able to either intervene and give an outcome that is favorable for the patient in the shortest possible time. What it does is we are able to, one, reduce mortality, and reduce the costs and increase the number throughput. It means where you are going to wait in a resus room, waiting for cardiobiomarkers to come for you to institute management. You have imaged the lung. You have seen that the patient has got does not have a pulmonary embolism. The results are there. Your D-dimers and your other markers are normal. Maybe the patient has got a simple pneumonia. You're instituting antibiotic management, and the patient is moved from one point to another or discharged in a cycle. But if we don't have those things, you are relying on clinical care, yes, but in this day and age, we cannot absolutely manage patients just based on clinical assessment. Yes, it's still very important, but the availability of point of care testing is very key. Overall, if you look at, I spoke about the value for $1 of care in a setup where we don't have point of care testing, and in a setup where we do, you find you can stretch that dollar by far. Your return on investment, so to speak, is much better when you have pure CT.
Yeah, I'd agree with you 100% on that. And I think one of the things that we should strive for, and I think we've learned it over the last 3 years, is many patients spend their entire life savings from to stay alive at the end of their lives. And our objective should not be to bankrupt the patient at the end of their lives. And if we can get a sensible tariff system for point of care ultrasound, and we can train on it, and we can get a tariff system for point of care testing, because I don't think people realize the affordability of this. You can do a troponin T, if I'm not mistaken, for less than $5.
Yeah, I mean, if you combine the cost of the device, the cassettes, and the labor, under $10, you have your troponins and your cardiac enzymes. So, as you said, you don't. We need the medical aids to come on board.
And I think we're working on that at the moment. But I'd be delighted to hear other people's opinions. I honestly believe that point of care imaging and point of care blood, urine, and stool testing will change the landscape for those doctors that don't want to be replaced by AI.
Yeah, I think that fear of AI is
Dr. Jackie? Sorry, Dr. Masiya, there's some questions in the chat. If you can just allow me to read them.
Yes, please.
Can you hear me?
Yes, we can hear you.
Yes. So Dr. Brian Kudzai Makamure, he's asking, are the point of care tests available in Zimbabwe yet? If not, when and where might they be available? Maybe I can just answer that. We have Yolande Lumbe on the call, who's the group head for medical disposables and devices. Yolanda, if you could just reply with your details, then you can contact her directly for that information. The next question is, kindly expand on how this device works. Does it require different reagents for different tests? Also on costs per test. And then the next question, maybe let's take one question at a time. Then sure. After you answer that one, I'll send you the next question.
So on the explanation, I think on the availability, Yolanda will answer that, but certainly there are the logistics of which she'll go into detail. She's the specialist on that. But coming to how the tests actually work, as I said, if we take, for example, your thyroid stimulating hormone, the patient comes in. These devices, they come with they are point of care small devices. You've got your immunoassay fluorescence machine, and you've got the incubator, a very small, tiny incubator, and it comes with already preloaded cards, like card devices which have got the information, SD cards, which have got information for each particular test or for each use, for calibration and all those things. So you collect your sample, and there are small little pipettes that are available. And then you use these tests. They use raw blood from a prick, or if you collect samples, the usual way we do, putting them in a test tube, you can use serum or plasma or whole blood. Then you draw the sample into the reagent that comes also preloaded on the pipette, each pipette for each single test, very tiny pipettes. Then you draw the blood there, and you put it in a preset incubator. Each test has they all operate at very specific temperatures from 8 degrees to 25 degrees, so it's not really a brainer. So, and there are numbers to the steps that you take. And after the third step, from the pipette into the testing device, you're supposed to do it in less than 1.5 to 2 minutes. So it doesn't really take that much time. Then you insert so let's say for the thyroid, when you buy, it comes with thyroid cassettes, which are clearly marked thyroid stimulating hormone. So you put your sample there on the test pot, and then you insert the test on the immunofluorescence machine. There's a pot there that you insert. And then once you insert, it gives you the time automatically on the screen that you need for you to read the results. But the results, you don't read them like manually. After the processing is complete, the machine prints out the results strip, which comes out with your number. Say if it's thyroid stimulating hormone, it will come with the patient number that you would have inputted and the result, and also it shows the reference range. And it gives, in some cases, it can give a red or blue or green marker to show where your test result is in comparison with the normal. So it doesn't really take much training. Obviously, it's just an issue of an online training, or during purchasing, there could be training availed for people, either virtually like this, but it doesn't really, it's not something that, it's done by people for all levels. You can have your nurse aides trained, or you can have your RGNs, you can have the medical practitioners do it themselves as well.
Another question is
Dr.
Taka Chipamanga. I hope I didn't mispronounce it. Are there any legal impediments to use these in Zimbabwe?
Yeah, I think that's a very good question. As long as it's designated point of care testing, there are no legal impingement from a medical council to use the devices. Obviously, there are cases when the device needs to be referenced by the Zimbabwe National Laboratory, just like rapid kits, when they come into the country, or they are in Zambia, or it could be Namibia, there is a national reference laboratory where there is in-country validation of the machine that I was discussing there. It comes with your WHO pre-qualification, FDA approval, and CA marked. But in some cases, in some jurisdiction, the countries might say, as part of general local use registration, they make you register the devices locally. But once it's registered in a country, then there is no legal impediment for you to use. Where the issues arise is what Jackie was discussing, where if it's a patient on medical aid, you might want to have an arrangement with the medical funders, which I think as a grouping, we should, to put the value proposition to the medical funds that this will indeed be cheaper for the patient, for the practice, and for the medical fund itself. So there is no legal impediment to registered practice or practitioner to use point of care testing.
I don't see any more questions now. I'm just going to encourage Yolanda to put her details, or I'll put her details on. Sorry, Doctor?
No, I had seen something. Oh, okay. It's information where it's simply sent on available POCT prices to the level of the intercare consulting rooms. I think there's somebody there who needs information. Yeah.
So I see that Yolanda has pasted there. Dr. George, if you can see also this current message, I see that you pasted your contacts there. But Yolanda has put the contacts for Zimbabwe DMD Healthcare. So everyone can just see there. So Dr. Jackie, do you have any more comments before we close?
No, I just really wanted to comment on the fact that point of care testing is becoming the gold standard, really, in terms of initial care. It allows you need to be asking a yes/no question. So if a patient presents with chest pain, and if you can do a subcostal view with a POCT machine and you have a negative troponin T, you can confidently not urgently call an ambulance. And I think that it will deliver, for a lot of GPs, I think that we often refer because it's going to take possibly 18 to 24 hours to get results on a patient that might deteriorate. And if we are able to definitively exclude things like ectopic pregnancy, myocardial infarction, we will be able to more confidently manage these patients in our own sphere. And I think that hospital at home is becoming a real demand from patients. They would much rather be managed by a trained nurse in their own homes than have to pay private hospital fees, especially when medical aids have huge shortfalls. So I think this is an opportunity for GPs to take back family medicine and to be able to not have to refer to specialist centers because they can exclude dangerous disease. So I'd love to hear Dr. Masiya's comment on that.
Yeah, I think you're spot on. The issue here is the aggregator is the GP or the family practitioner. They see the patient, but because of what has been happening, the consultation is paid, and you look at what is remaining. The patients would opt to go where there's a reduced consultation, but are willing to pay for huge costs for any other ancillary services that are ordered by the same GP. And when they look at if a GP sends, for example, a CT scan, when in their mind they'll say the cost to visit that GP included the CT scan, and it's considered as an expense generated by the GP for probably because they don't have other testing modalities that could reduce the need for a CT scan as an example. But if the GP or the family practitioner or the primary healthcare provider of any sort is empowered with point of care testing for be it metabolic diseases, be it another infectious disease, it means that everything is done under one roof. And we are able to control the cost of care because we've got streamlined costs that come with point of care, which being less costly than the bigger laboratory-based or radiology room-based tests. Those are still important and they have on their own space. So what you are saying that the GP or the primary healthcare provider would take back the ownership of the care of patients, it is based on that. It is based on that ability to be able to offer a broader spectrum of testing at reduced costs or affordable costs, at the same time having all the information in one visit and be able to deal with the case definitively. And if at all, escalate care to specialists or to hospitals or to for further testing based on real data. So that's what you're talking about, getting that cycle back to the managing general practitioner.
And I also think it's a win-win situation. I've spoken to 2 radiologists in the last sort of 2 days. I'm actually going to see the peri tomorrow with one of them. And the reason it takes 48 hours sometimes to get an ultrasound scan is because the radiologists are doing dating scans. And literally a midwife could do that with point of care ultrasound. So we need to be giving the busy radiologists the difficult stuff, the CTs, the MRIs. And as good GPs with good primary care skills, we need to be using ultrasound and testing so that we refer in an appropriate manner. This stuff allows us to appropriately triage, and it takes the burden of the probably 70% of stuff that the radiologists are dealing with that are X-rays and ultrasounds away from them, and they can focus on the difficult stuff. So I think that everybody wins out of this situation.
Yeah, and just to quickly add on that, if we improve our diagnostics based on point of care testing, it means we can streamline more cases. We are not missing. You saw on the preamble that 13 million people in the African region of the International Diabetic Federation are walking around with diabetes without knowing. If you streamline those cases, to pick them up, it means more referrals to other faculties of healthcare, and of course with the aim to reducing complications, because there's timely. And also, if somebody saves on the preliminary diagnostic level, it means they've got more money remaining to actually get, if it's surgery, if it's a biopsy, if it's an admission by a physician, they have more money to get medication that is appropriate and that they can monitor on, that is evidence-based. I mean, instead of starting one on this medication, then you come back, you review, you realize that that's not the case, then you change them after they've paid for a certain pharmaceutical product. So this whole thing would help care to be focused and cost to be limited.
Thank you so much, Dr. Masiya, Dr. Stone. I will just give you a couple of seconds to just say a few last words before we close the session. Unfortunately, it's time. So before I do the vote of thanks, if you have any last words.
Yeah, from my end, I think this is just a stimulation to the colleagues to consider point of care testing as not a luxury or as an afterthought to their practices, but to put it as a sticking thing that is outstanding in their practices, because the advantages we've already discussed.
Thank you so much.
I think
yes, Dr. Stone?
My final comments would really be that the affordability of point of care testing, if you look at the patient, we did a patient on Thursday where a week ago, where we went in, a lot of the anesthetists have sort of said, well, we can't charge for this. But the point is that we managed to do a subacromial bursa in 40 seconds because we put the probe on and one person was directing the other doctor to put the needle in the right place. So I think that this kind of approach, first of all, the patients are delighted because it restores confidence, because they can see the image themselves, they can see the needle going into the right cavity, and they can feel the local take effect, and then obviously the steroidal take effect later if we're doing musculoskeletal stuff. But I also think that it gets rid of the hassle factor for the patient, because in Harare at the moment, if a patient is sick, they're going to spend 2 hours waiting to see the doctor. Then they've got to go somewhere to have the scanning done. The bloods have been sent off. And I think personally, I've spent more time chasing bloods than I have actually taking them. So this puts everything back in our control. And it's about taking back control as family practitioners. And it's about affordability for the majority of patients that cannot afford 150 US for the bloods and 100 US for the investigations. And then they argue about a $10 shortfall with the GP. So I just think that this is a brilliant solution going forward.
Thank you, Dr. Stone. So we've come to the end of our session, this week's session. I just want to remind everybody that we will be having weekly sessions on different topics. So just look out for our ads on these different topics. So I would like to thank our speaker for today, Dr. Cletos Masiya, our partners, which includes the various Avacare companies, as well as the technical team behind the scenes. Be reminded that this is also being live streamed on YouTube, and it's available on our Intellectus Campus YouTube channel. And also, I would like to thank everybody who came and participated on this platform. Next week's session on Wednesday, 5th of July, we will have Dr. Jackie Stone speaking on early management of substance use disorder, understanding the causes and stages. So before you log off, please kindly fill in the form so that you can get your CPD certificates. Thank you. Have a good evening.
Thank you. Cheers, everyone. Bye.